just as a brief introduction, an appreciation for the invitation, certainly from the Academy of Sciences in Honduras, because Dr. Mario Lanza gently recommended not only myself, but us to Dr. Huete. And so I think it's going to be quite similar messaging you're going to hear with our presentation. It's a good segue from Dr. Victoria's presentation and yesterday's. I think what we're going to also put in perspective is the reality that amidst this pandemic, this disease will be most likely is already a so-called neglected tropical disease. And we are going to have to face the challenges of the morbidity that it will cause and the long-term effects and impact. So we not only are going to be challenged with dealing with the urgent need, but certainly also what is going to have to be done in the years to come. And as a punchline, I already can tell you, I think you're going to hear the same message of where the failures have been, what the lessons learned are, which is, you know, that there's a need for champions and leadership, effective, transformational, that we need to focus on multidisciplinarity and interdisciplinarity, that it's essential that the decisions are made on the basis of evidence, that we have to communicate better as scientists, but that also we need to start looking at how to long-term reinforce the local capacity. So it's gonna be a little bit of a tag team. I just wanna give Peter the benefit of saying hello. Peter?
Yes, thank you, Dr. Bottazzi. Greetings to everybody in Nicaragua. You know, I think, you know, I was listening very closely to the last presentation, and it is amazing how we've also come to the same conclusions, that overwhelmingly COVID-19 is a disease of the poor. It's a disparity, it's a disease of extreme poverty. We're seeing that across the United States, although it's not often really discussed that way. You know, Mary Elena and I wrote an article for PLOS at the beginning of the pandemic predicting COVID-19 might emerge as a neglected tropical disease, and I think that's indeed turning out to be the case, and the last presentation reinforces it. And then the other point that was made that really struck me is the impact on indigenous populations, and we're also seeing that in the United States. And I think there's historic decimation of Hispanic communities in the U.S. as well as indigenous communities, and maybe at the discussion we can highlight that a little more, because I don't think, you know, I think that's also a trend that we're starting to see. So maybe Mary Elena, you want to go ahead and begin, and then
yeah, sure. And I just want to put it in context with Peter. We always like to give like the 30,000-foot view of what's the landscape and what has really been happening. And I think all of you know that one of the issues that we're seeing is that we need to make sure that certainly research and development and the way that we approach global health is certainly in context of many good things that have already happened in the last couple of decades. And here is just to remind us that probably everything that we do fits within the fact that at least in definitely the last 2 decades, we have had some very seminal and very important attempts to rally all the globe, rallying into following, of course, very audacious goals with the MDGs as well as the global goals. But the fact that, again, like we heard yesterday, the need for the academies, the need for the societies, and how we can certainly work in an interdisciplinary manner. And just in the area of tropical and what we call emerging health technologies, I want to highlight a couple of things that also bring the attention of why the importance of better branding ourselves, better communicating as scientists. The fact that I know, for instance, with Peter, we have worked, you know, years to certainly position the brand of these neglected tropical diseases, you know, that now of course are you know, converting themselves into even the emerging diseases. the fact that there's been the creation of very important global agencies, and we think that we need to leverage that. At the same time, we appreciate that they are complicated global agencies. But one thing that I want to also highlight is that there's been these models, these so-called partnership type of models, right? So I'm going to give certainly the example of our model, which is the product development partnership model, which were launched again back in the early 90s to try to really move these technologies with the whole purpose to make them public goods and that they would be achievable, affordable. While at the same time, a similar ecosystem was being built in the biodefense centers of excellence, at least here in the US, but all together with, again, this ability of open access and a little bit more transparency in how we communicate. So just to introduce myself, and then I'll send it back to Peter. I mean, our school and our Center for Vaccine Development, we have been in operations for the last 20 years. For the last 10, we have been in Houston at the Baylor College of Medicine and Texas Children's Hospital. We really focus on three major missions. One, of course, build sustainable and innovative plans of how to raise the awareness to specifically fight these diseases of the poor. At the same time, bringing the development and testing of low cost and effective vaccines. And at the same time, trying to really change and break the paradigm and not work in a space where we forget that we need to build local capacity. So starting with each of them, we're going to give you some examples of some of what we've seen, the lessons learned, and what we think could be a good strategy moving forward. So Peter, back to you in the first framework.
Well, thanks, Mary Elena. This slide gets to one of the global trends that we've been noticing about COVID-19, and it's been true of other illnesses as well. You know, when we think about poverty-related neglected diseases or neglected tropical diseases, we immediately gravitate towards the poorest, most devastated countries of Africa or in the Western Hemisphere, Haiti. But you know, when I started a few years back looking at the data from the Global Burden of Disease Study and also from the World Health Organization, and numbers were pretty concurrent. Overwhelmingly, the world's poverty-related neglected diseases on a numbers basis were actually in wealthy economies, in the G20 countries, the group of 20 economies. So in South America and Latin America, it was Mexico, Argentina, Brazil, and in the United States as well. So it's the poor living among the wealthy that actually account overwhelmingly for the world's poverty-related neglected disease and neglected tropical diseases. And you might say, well, why is this relevant to COVID-19? Because I think COVID-19 is going by that same pattern. The poor in the G20 countries. I mean, look at the top countries affected by COVID-19. It's the United States, Brazil, India, Russia, and South Africa overwhelmingly. So, and these are all G20 countries. So the point is, it's not so much a resource issue around COVID-19, it's an advocacy and awareness issue. And this has a lot to do with international cooperation for vaccine development. We need the G20 economies working better together in this concept of vaccine diplomacy to build vaccines together. And unfortunately, it's not really panning out that way either. In addition to not getting the G20 countries on board, we're not seeing that cooperation. We have this concept of what's unfortunately called vaccinationalism, where you have the Chinese vaccine, the American vaccine, the Russian vaccine, the British vaccine. It was never supposed to work that way. Next slide, please, Marilyn. And then specifically with the Central Latin American region, we are seeing that while we had a lot of gains early on after 2000, over the last 10 years, we've started to see a slowing, a halting, or even a reversal of those gains in the Central Latin American region. And by Central Latin American region, not only do we mean Mesoamerica, meaning Mexico and Central American countries like Nicaragua, but also looking at Panama, Colombia, and Venezuela, what we've seen are increases rather than decreases in the number of cases. And in particular, it's where a lot of social determinants are feeding into this, particularly shifts in the illegal drug trade, which is where now a lot of the drug routes are being rerouted through the Northern Triangle region of Guatemala, Honduras, and El Salvador, political instability, collapse in Venezuela, and then together with climate change. So social determinants working together with climate change, that's created this dry corridor across many parts of Central America and leading to very interesting but very worrisome kidney disease on the Pacific coast of Nicaragua and elsewhere in Central America. And once again, that marginalization of indigenous populations. So again, it's these this shifting poverty that we call blue marble health, the poor living among the wealthy, but also these external forces like shifts in drug trade and political collapse, climate change, that are the new drivers of this 21st century disease. Next slide, please. And in trying to find a unifying feature of these is hard to do, but you know, if you look at what are the big picture shifts, poverty is still dominant. This blue marble health concept, the poor among the wealthy, is a huge one. And again, climate change, urbanization, deforestation, conflict, and political destabilization. Now, there have been a number of articles about climate change, but our premise is that it's not really climate change by itself. It's climate change coming together with these social determinants of urbanization and conflict and political destabilization. And this will be the topic of a new book I have coming out at the end of this year on looking at this. And just go back one more slide. And we're still trying to come up with a unifying theme. There's been those who have thrown around this term, the Anthropocene, which basically refers to the fact that when you look at the big geological epochs, the Pliocene, the Pleistocene, the Holocene that began at the end of the Ice Age, now humans have so profoundly altered our world that we're now looking at these Anthropocene forces as the big drivers. Maybe I'll switch over to you, María Elena.
Yes, so I think this, puts it also in perspective that, we early on, back in early April, were already predicting that COVID-19 would most likely become the next tropical disease. And again, it's primarily because of now we're going to start seeing not only what we saw about the mortality rates, but what is going to happen with these unprecedented levels of morbidity. What is going to happen with the fact that we know that during this year, we've also had a lot of interruptions in other key public health programs because the health systems are pretty much collapsed. We've already also seen a huge rate of decline in vaccination rates. So what is going to bring us, with the compounding effect of this pandemic on, especially in our region where we still have to deal with dengue, we still have to deal with, a lot of other certainly vector-borne diseases. And we don't really even know what's going to happen with the flu season, which I believe we also discussed yesterday. So this again is what Peter is trying to kind of put in context with how we're going to have to also not only plan for a short-term solution, but this is really something that we need to start planning for, really long-term solutions. Now, I want to really shift quickly to what's going on with, of course, vaccine development. As you know, the other pillar in our school and center is to try to develop global health technologies. I know there's a lot of work around the complexity of not only developing, producing, of course, testing, but ultimately even delivering the vaccine. So we, of course, have been working for years. We have at least 10 years of working on a on a coronavirus vaccine. So I'm going to tell you actually a story which put it in context. So yes, we hear about all these different categories, inactivated, attenuated. We of course focus on protein subunit just to highlight that these are the vaccines that we know have been licensed around the world, but we are at the same time advancing vaccines that are considered novel technologies and have never been licensed and don't have a lot of precedent on how they're going to certainly perform, and as well as how in the long term their safety. So it's a complicated landscape. So we also have been focusing on how can we really move towards preparing those three pillars, the production pillar, the testing pillar, but at the same time the delivery pillar. But going back to maybe not complicating ourselves, but looking at, bread and butter technologies. And that's the story that I have to tell you. I mean, we focus on recombinant protein technologies. We have, of course, decades of experience with other vaccines, including the coronavirus. But this slide is really just to highlight to you that our learnings, and it's a very modest, laboratory scale that we have here in Houston. But the blue line represents to you that in less than 6 months, we managed to really reproduce what we had been working for a decade in the area of coronavirus vaccines, to the point where we have, bridged very important alliances like PATH and Millipore Sigma and Merck, for example. But more importantly is that now our vaccine has been licensed to a large-scale manufacturer in India, and their intent is that using again a proven platform that can readily be technology transferred. This platform is very known around the world, including Latin America. It is already a platform that is very affordable. It also very scalable. There's other very safe profiles of other vaccines, including the hepatitis B vaccine. And it can, albeit may have the perception that it's behind in other vaccine programs, it can very easily catch up very quickly. And this is where I think we also should start thinking of how we can reproduce this concept of partnership where you design and engineer, and albeit we start from being here based in the US, working with global partners, including Biological E and PATH, for example. And here is an example of India. But how can we then replicate this in the Latin American region, and more especially even in the Central American or Mesoamerican region? And it doesn't mean that you have to fit all the pieces, but we have to start building this ecosystem in the region. And I know there's some champions in Brazil, and certainly albeit some level Mexico, Argentina, but we can do better. I mean, it's amazing how Latin America just does not have all the pieces so that we can be self-sufficient. And that's, I throw back to Peter and go back to why, therefore, communicating and how do you say to really shape the policies. It's important that we increase our outreach. So Peter, back to you.
Well, I'll just, mention again back to the last presentation how the misinformation around COVID-19 and vaccines is so widespread. And, one of the realities is we have a pretty aggressive anti-vaccine movement in the US, and our premise is that it's spreading globally. So both Mary Elaine and I have been working hard to do a lot of public outreach. And because I think one of the problems that I'm seeing is we don't hear enough from the scientists directly. Everything is filtered through the politicians and the elected leaders. And that only takes us so far. And it's really important that people hear directly from the scientists during this COVID-19 epidemic. So I'll be curious to hear what the situation is both in Central America and Brazil, but we've been working very hard to be out there explaining the science of COVID-19 to the public and around vaccines as well. Next slide.
So this one, Peter, is for us to give a little bit of maybe a landscape of what's going on here in the US. And of course, your experience and especially what's going on in Texas. So can you take it on?
Yeah, you know, we've seen now a big, you know, we thought we were coming down in March and April to reduce the transmission of COVID-19 and not wanting to reproduce what we saw in New York City and trying to avoid this for the rest of the country. And unfortunately, because of the lack of adequate messaging coming from the federal government in the US and the White House, and the fact that we never really adopted a national strategy, the idea was to leave it to the states to make decision. And again, like Brazil, the White House kept on reverting back to magical solutions like hydroxychloroquine or extracts of oleander and this sort of thing, and failing to create a national strategy. This created an opportunity for the virus to come back in a big way. So we've had now throughout the summer a massive resurgence of COVID-19. So for the last 7 days even, the US still leads the world in the number of new confirmed cases and the number of deaths, and it's been this way all summer. I've been trying to put forward a plan, which I call our October 1 plan, to get the nation to more aggressively try to contain the virus again, but it's just not happening. This is not going to be a challenge of this administration. So it's really interesting what happens when you do not have political leadership, when populist governments decide that they are going to allow this virus to run its course and respond by denying it's a problem. And we're seeing the devastation in the US and Brazil and in now Russia and elsewhere. And I think that's the last slide, Mary Elaine, maybe.
Well, there's just again the little bit of summarizing what the punchline I mentioned at the beginning, right? So clearly, you know, who have succeeded clearly at some level have had some leadership and certainly, you know, some guidance, that there were some roadmaps and plans set, at least with target dates and target goals, especially this concept of levels of virus containment, benchmarking that containment, and therefore making it a little bit easier for, you know, the public health to be able to work, you know, including, you know, making a little bit more feasible the contact tracing. But it has to be, you know, with political will and agreed, and that the community agrees to this, you know, certainly having established biotechnology capacity for self-sufficiency. As you know, it became clear with this vax nationalism, right? You know, those who have ability of making their own are pretty much eventually protecting their own populations, and we're gonna have to see if there's gonna be excess capacity to then come and rescue those who don't have this biotechnology capacity. And again, the fact that we need to definitely improve in how we can strengthen partnerships, collaborative, interdisciplinarity, and of course, science, communication, and engagement. So no more different than what you've been hearing from yesterday and today, I'm afraid. So back to you all for any questions. Thank you so much.